we start our case presentation with this 64-year-old female presented with يعني lower limb weakness back pain and all these things. So full spine X-ray was ordered for her evaluation. So do you see anything? طبعا AP and lateral by the way.
شوية اكو degenerative changes in the spine.
تمام degenerative changes. Some osteopenia.
Yes. اكو هاي paravertebral.
There is something not proper here.
Yes.
Try to see it on the other projection. Just scroll. Okay. Scroll. Okay. Do you see anything that, I don't know, يعني attracts attention?
This side, there's a bulging in the left.
This is aortic arch.
Aortic.
Keep in mind this is overexposed due to, because it's a spine X-ray, not a chest X-ray. So the aim is to see the vertebrae. So do you think anything looks interesting here or no? And if no, what to do? See, here it's not very like attracting things, but I think if we look carefully, we can see something in these vertebrae that does not look quite right. They appear to be fused together. If you see on the lateral aspect, here there is something. Of course, it's not definite. It's not obvious even. But if we have to guess on something, then this would be our best guess. So what would you like to do next? There is a suspicion. That's it. It's just a suspicion.
CT.
Chest, abdomen, and pelvis CT was ordered for her for full evaluation. What do you think is there and what to do? And give me your opinion.
So CT section, axial.
Axial, chest, abdomen, pelvis CT scan, soft tissue window with contrast showing what do we have? Basically, there are three main findings. One is insignificant and two are very significant.
There is this hypertense.
Okay. Right. First of all, if you are looking for vertebral pathology, you have to go to bone window, right?
This one's heterogeneous.
Mm-hmm.
This one. Yes. Mixed elytic and sclerotic.
Mm-hmm.
Distracting the vertebra.
Mm-hmm. What else?
This.
There's a big prevertebral soft tissue component compressing the trachea, displacing it anteriorly, compressing the superior mediastinum. What do we have here? Do you think there is First, I would love to go into soft tissue window to evaluate the soft tissue component. صح؟ زين. Where is the lesion?
Revertebral.
Go up. Where is the vertebra involved? Okay. So what do you think we have here? If you look carefully, first you'll see this exit foramen is definitely not normal, and the vertebra is eroded from here, indicating this lesion is extending into the spinal canal. It's compressing the spinal cord, it's causing the patient weakness. Okay. So now to summarize our finding till now, what do we have?
Destructive lesion in the vertebra
Okay.
plus vertebral soft tissue mass, causing the compression of the airway and esophagus.
Okay.
With extension to the spinal canal and narrowing of the
Perfect.
exit foramen.
Zia, what's your differential diagnosis? Let's go back to the bone window. What is your differential diagnosis for a 48-year-old? I think she's more than 48, maybe 50 something, 58. Anyway, female patient with solitary vertebral lesion. Do we have any other vertebra involved?
No.
Or any other bony involvement, let's say? Okay. So, metastasis of course, number one. What else?
Could be infection.
Infection. What would distinguish infection from other? The soft tissue component is not in favor of infection. Okay. Second, we have you need elevated white blood cell count, CRP, ASR, and all this. Clinically, she's a slow process. She's not acute case. There, bad. Infection, metastasis. What else? Lymphoma. Okay. What else?
Any hematological.
Hematological. Would it be, you mean leukemia or these things, right? But it will not affect single vertebra. It will be generalized. There. Look at this vertebra. Look at this vertebra. What does it look like? What does it look like?
Eosinophilic histiocytosis.
Why you say that?
Because the shape of the vertebra.
What's the shape of the vertebra?
It's polka. No, polka.
Polka dot هذا هيمنجيوم ما لنا علاقة
It's
هاي.
shaped vertebra.
It's shaped in this age?
No.
Come on. On axial? Huh. Expanding. It's collapsing. It's not expanding.
Mini brain sign.
Mini brain sign. This is typical mini brain sign. Solitary vertebral involvement. Okay. Which is, some people say it negates the need for a biopsy. It's so typical. When you see mini brain sign, it's plasmacytoma. Now, we have made our professional diagnosis as a solitary vertebral lesion with a plasmacytoma. Okay? احنا قلنا three findings. If we don't see it, the other significant finding. If we don't see it and we don't report it, this patient will die in surgery. Yeah, I think now it's good. Yeah.
To highlight the mother artery.
Sorry.
invaded or the
There are multiple pulmonary emboli. شوف الفلنج ديفكتس كده. انت في البدايه كده تعمل articulation باللنج which is due to bilateral by the way. شوف الليفت. You see the left filling defects? شوف هاي. هاي. There are multiple bilateral. It's not CT angio. It's just abdomen pelvis. But the filling defects are there and they are obvious. So the patient, if she takes general anesthesia and the anesthesiologist have no idea that she has pulmonary emboli, it might prove fatal. So you can see there is some congestion in the lungs, probably related to the pulmonary emboli. Okay, it's يعني on the border of having multifocal pulmonary infarctions. Okay, high second. Then the third finding اللي هي not significant. I don't care if you report it or not. For the sake of time, she has a gallbladder stone. Okay, then now the T1. You can see the spinal cord compression, the prevertebral extension. Let's go to the T2 fat saturated image. Okay, it's severely compressed, the axial images of the affected area. قول لي هذا مو من برين. برين لو مو برين. And the surgeon went in, resected the tumor, put a graft, and immediate improvement was noticed. Let's see the post-contrast images. These are the post-contrast. You see, it's not that much enhancing. It's hypo-enhancing, let's say. See here? This is post-contrast. It shows some, especially the intraspinal component is enhancing, but not that much. So this is a 36-year-old female patient with mouth dryness and complaints from that and some pain in the يعني هذا T2 facet. What do you see? Tell me.
Okay, the bilateral parotid gland is enlarged, contain multiple cystic spaces. Okay, just this. But the other should see the contrast and.
Why contrast? No need for contrast.
No,
What's this?
Green.
What is this sequence? What is this?
هذا سيالوجرام.
This is MR cyalogram. Okay, MRI cyalogram. So this is MR cyalogram showing both parotid gland to be markedly enlarged and replaced by innumerable cystic lesions in a 36-year-old female patient. This is the most obvious Jogren syndrome you will ever see in your entire life. ما ممكن تشوف Jogren syndrome more than that. يعني. You can see the cystic spaces.
Yes.
Okay. And we go to the thin cuts. هذا ال 3D. Okay, called the source image or the raw data. You just go to the 3D here, get this thing here, and you can just scroll it and you can increase or decrease or whatever. The spinal cord, okay, and you can see the canal of the duct. شوفوا شلون حلوة. Okay. And we can do other trick like go into 3D MPR like that. Okay, we take this, we put it on the gland and a little bit rotation. Okay, and then we increase the slice thickness like that. Okay, and just rotate it like this, and you'll have a very nice demonstration of the gland and the cysts, and this is the duct. You just remove this. You can go like this, magnify. You can see the duct going here. Okay, if we increase even the slice thickness even more, you will have this thing here. طبعا the gland, the duct is not very well seen because of the cysts surrounding it. Let's go to the other gland maybe. See here, this, if we put it like this,
dilated.
it's a little bit prominent, but there's no filling defect, no stones in the duct. Okay, but you can see the cystic lesions, cystic spaces connected to the duct, which opens into the mouth in the, where does it open? Second.
Upper.
Exactly. Opposite, the second upper molar tooth in an MR cyanogram. Okay. Very nice, I think. Okay. Thank you. See you next week.